Hi, Nursing 322. My name is Megan Crothmell. I will be presenting on the research study Family Typology and Appraisal of Preschoolers' Behavior by Family Caregivers. The study was done by Sally P. Koch and Leslie C. Moore. Significance of the problem. I've attached some data here identified from the study. 2.3 to 7% of preschoolers are prescribed psychotropic medications. 40% of preschoolers' parents have concerns about their child's behavior and development, and 17.5% of parents worry about how their child socializes. In families without supportive, nurturing environments, preschool children may fail to learn impulse control and appropriate communication skills, which may lead to development of aggressive biting and scratching and rebellious behaviors such as temper tantrums. However, preverbal young children often use behaviors such as biting or hitting to communicate anger and frustration. This can be misinterpreted as a behavioral issue if not understood by the parents. Some have parents who may be encountering serious stressful events, who are experiencing depressive episodes, or who lack social support to accomplish parenting tasks. The significance of this problem to nursing practice. Nursing professionals, and in particular school nurses, pediatric nurses, and nurse practitioners, need to be cognizant of the role the family plays in the development of the child and the health and learning outcomes of the child. Nurses can also evaluate parent and family dynamics when behavior problems occur with a child. Families who are vulnerable may have difficulty adapting to the stressor and need additional support from healthcare providers. Healthcare providers can additionally supply education to families about how they can seek treatment or help when they deal with stressful situations. The purpose of this study was to use the resiliency model of family stress, adjustment, and adaptation as a theoretical foundation to explore family factors associated with the primary female caregiver's appraisal of her child's behavior, the extent to which the primary female caregiver's appraisal of her child's behavior may be distorted, and the child's level of risk of having a behavioral problem. This translates to 3 questions the study asks. 1. Does female caregivers' appraisals of children's behavior differ by family type? 2. Does distortion in family caregivers' behavioral ratings differ by family type? And 3. Does level of risk of children having behavioral problem differ by family type, controlling for distortion in family caregivers' behavioral ratings? There was not a hypothesis used for this study. The model, as stated earlier, was the resiliency model of family stress, adjustment, and adaptation. This was used as the framework for understanding the female caregivers' responses to their preschool children behaviors. The model posits that a family's adaptation process is a dynamic response to excessive demands that occur during their lifetime together. As we all know, we encounter stressors maybe even every day in life. Family type is based on a family's level of hardiness and cohesiveness. Vulnerable families are characterized by low hardiness and low coherence, which I will get into more during the data collection section. The county's Board of Education and the university's ROB board gave the researchers consent for the study to go forth and select participants. The participants were voluntarily participated in the study, and they self-reported they met criteria for being a participant. They were given identification numbers, and files were stored in a locked area of the principal investigator's office. The participants were not forced to answer questions. Those that left questions blank were eliminated from the study during the data analysis portion. Additionally, the sample size started as 330 participants and dwindled down to 117. This indicates to the reader that participants were not forced to stay in the study after they began to participate. The population. It is stated that most of these families' incomes were below state poverty levels, and the county's race demographics were 54.9% Caucasian, 41.5% African American, and 3.6% for other. The sample was 82.8% African American. Most had a high school diploma, which was 84.3% of the sample. Nearly 1/3 of the participants were laid off or looking for work. This was 27.5%. And 10 of the caregivers, which was 8.5%, had a previous diagnosis of depression. As I said earlier, 117 females were the sample size, and this was done as a convenience sample. The sample was done at the Head Start preschool in southeastern United States. It took place on 2010 during orientation day for preschool. They used a cross-sectional correlational research design. This involves collecting data from a population of varying demographic characteristics at the same time. A correlational research design involves determining the relationship between 2 variables. The study is observational and data collection only, so no interventions or variables were used technically. The study does compare how different types of families, specifically regenerative and vulnerable, identify their child's behaviors. So this could be interpreted as variables in the study. There were 5 areas in data collection. Demographics and family description. The MacArthur Socio-Demographic Questionnaire, which was done by Adler and Stewart in 2007. This was used to obtain characteristics of the participants, including self-rated social status of participants in poorer communities. Additional questions not asked in the MacArthur Socio-Demographic Questionnaire were about the participants' age, race, marital status, smoking status, alcohol use, and diagnosis of an emotional behavioral problem in the preschool child, and the presence of another child in the home who had a diagnosis of an emotional behavioral problem, because oftentimes behavioral problems can be genetic. Appraisal of child behavior. To assess appraisal, female caregivers were asked to compare their child's behavior to the behavior of other preschool children. This also was done in a ladder design, which the demographics and family description was as well. So families scored their child from 1 to 10, 1 being poor and 10 being the best. Family typology. I didn't mention this earlier, but family typology is the pattern of functioning or behaviors that describe how the family works together and manages problems. Median splits were used as the cutoffs for forming groups. Participants rating their family as high in hardiness and high in coherence form the regenerative resilient family group. Participants rating their family as high in hardiness but low in coherence form the secure family group. Participants rating their family as low in hardiness but high in coherence form the durable family group. And participants rating their family as low in hardiness and low in coherence form the vulnerable family group. Family hardiness refers to the internal strengths and durability a family has, and this was measured on the Family Hardiness Index, the FHI. It took approximately 10 minutes to complete and consisted of 20 items. I think the family typology is the most important area of data collection the study did because it refers to all 3 of the questions. Risk of behavioral problems. Using the T-score, the child was classified as having normal risk, elevated risk, or extremely elevated risk of having behavioral problems via positively versus negatively worded questions. So the questionnaire asked positive and negatively worded questions about the caregiver's child, and she would answer yes or no. Distortion in behavioral ratings. Ratings were considered distorted if any of the validity indexes resulted in a caution. Each index is reported as acceptable, caution, caution low, and caution high, and extreme caution. The response pattern index was formed by counting the number of times an item response differed from response to response. And scores greater than 8 were cautionary. Additionally, the data collection portion lasted 30 minutes because that is how long the questionnaires lasted. ANOVA was used to compare means of behavioral appraisal scores across the 4 family types. A chi-square test was used to evaluate the association between family hardiness, high and low, and distortion in behavioral risk ratings. ANCOVA was used to assess the association between family type and behavioral risk, which is the BASC2 BESS scores and T-scores, controlling for distortion in ratings, which were yes or no questions. The BASC2 BESS scores were used for risk of behavioral problems and distortion in behavioral ratings. The FHI was used for the family typology, and the MacArthur Socio-Demographic Questionnaire was used for appraisal of child behavior and demographics and family description. The findings emphasize the importance of family factors, hardiness and coherence, on young children's behaviors. Family typology was not associated with the family caregiver's appraisals of her child's behavior, though. Distortion of the caregiver's ratings of her child's behavior was not associated with family hardiness, specifically, but was associated with having a child with an elevated risk for behavioral problems. So, a decrease in hardiness meant an elevated risk in behavioral problems. Families classified as vulnerable were significantly more likely to have a child with elevated risks of having behavioral problems than families classified as secure or regenerative. Question 1's findings were regenerative groups appraised their children better than the vulnerable group. Regenerative groups had a mean score of 16, and vulnerable groups had a mean score of 14.7. Findings in question 2 were that caregivers with a distortion in their ratings of children's behaviors were significantly younger and had less education. There was no significant association between family hardiness and presence of distortion and female caregivers' ratings of their child's behavior. Lack of parenting knowledge played a role in this distortion, as they may have misunderstood behaviors, possibly due to their young age and having less education. The findings in question 3 were that scores for children of vulnerable families were significantly different from those of secure families and regenerative families. It was surprising that the participants whose ratings were distorted did not appraise their children's behaviors differently, possibly due to being tired after answering so many questions. This could also be seen as a limitation in the study. Implementing measures to help strengthen families, such as screening for family vulnerability with the FHI and FCCI maternal depression screenings done with the Center for Epidemiological Studies Depression Scale, or screening for stress with the Perceived Stress Scale, may decrease the behavioral problems that occur in the preschool child. By screening for problems, healthcare practitioners can step in and help problems before they truly become a problem and affect the child or the family. Systematic assessment should be done on children in relation to their social and academic development. This should be done by trained nurses or social workers as part of evaluating family dynamics when behavior problems occur with children. That was the implications for practice, and I hope you enjoyed my presentation. Thank you for watching.